Thank you, Adam, on behalf of ImpediMed for inviting me to participate in this webinar series. During my almost 40 years of clinical practice, 33 years have actually been spent in cancer care and lymphedema management. Having introduced a prospective surveillance model of physiotherapy care in 1991, which eventuated into a PhD study for early detection and management of physical impairments from breast cancer treatment, exercise prescription has been an integral part of this management for all cancer treatment. Bioimpedance spectroscopy has been incorporated in this model, initially in research and subsequently in my clinical practice since 1995. In this presentation, I will discuss the practical implementation and approaches in clinical practice that I use to increase participation in regular exercise, physical activity, and reducing sedentary behaviour in cancer care. Brent has outlined the guidelines and recommendations in his presentation that just preceded this one, and over the last 30 years since the work of Mackenzie's thrust dragon boat training and racing for breast cancer survivors into the forefront, the body of evidence has increased progressively, with guidelines being developed, with the most recent ones presented by Brent, including the COSA 2020 position statement. In these guidelines, there have been numbers of recommendations that have been put forward, but the consensus in general is 150 minutes of moderate intensive exercise and resistance training 2 to 3 times a week. I'd like you to take a few moments just to consider what is the main challenge for you when you are addressing this recommendation with your patients. Participation in physical activity and exercise is encouraged in all phases of cancer treatment and beyond. Research evidence is increasing for cancer patients to engage during neoadjuvant and primary treatment and following completion of their primary treatment, which may include surgery, chemotherapy, radiotherapy, and ongoing hormonal and immunological therapies. Following cancer treatments, patients can be left with impairments of side effects of treatment, and these may require management but also be responsive to specific exercise prescription and physical activity guidance for symptom reduction. Living with recurrence and further treatment in the presence of advanced disease states may also be improved with engagement in physical activity, specific exercise prescription, as well as reducing sedentary behaviour during that course of treatment. Growing evidence supports the benefits that can be achieved with regular exercise and physical activity, but it should also be remembered that different and independent benefits can be obtained by reducing sedentary behaviour in the general population, but this has not been studied in cancer patients to any extent. Brent defined exercise and physical activity, but I also believe that addressing sedentary behaviour in cancer patients may be a starting point to effect change for many of our patients. However, despite this level of evidence, we have similar participation rates in cancer research trials of about 30%, which seems to reflect what we see in ongoing long-term participation. Increasing levels of participation and reducing sedentary time requires a facilitating and effective change in our patients. You may be familiar with this behaviour change model, but also social cognitive theory may be appropriate since we are focusing on the individual for change. These topics require more time than possible during this presentation, but it is an essential part of my approach to facilitating change to increase participation. I would ask you to consider your reflection at the beginning. What is the main challenge for you when addressing participation? Where does it fit in the behaviour change cycle? Another way to express the changes, which I discuss with patients, is the pre-contemplative being, it's not for me, I really don't know much about it, to actually contemplating or thinking about it. Then it comes to working out what to do and how to do, which is where we would have a lot of impact. Then there's the doing it. And then, of course, the biggest challenge for all of us is to keep doing it. When it comes to a cancer patient, there has been some work that has looked at the barriers to physical activity self-efficacy amongst breast cancer survivors. In talking to patients, I don't think they're very different across most cancer groups. And when you read through this list, I don't think it's that different from most of us when we need to get out and get active. It is helpful with patients to work through what are the barriers to them actually being participative in exercise or physical activity, but also working through what are their enablers. Sometimes it's not about reducing the barriers, but actually enabling a patient. When we consider the lymphedema patient, there may be additional barriers to them actually participating in exercise. Specific to lymphedema, things around the swollen limb, and also changing paradigms around what they may have been told in the past for those of our patients who've continued to live with lymphedema for some time. There also is the fear around making their symptoms worse, also because they may not have participated in exercise and physical activity for some time. There is an element that needs to take the retraining, the education, the practice of different activities to gain competence. Incorporating all of this is into the program that I have developed with my patients and is used throughout my private practice, called Movement Opportunities for Vitality, Energy and Stamina. In other words, Moves for Life. It is an approach that encompasses the philosophy that we all move. How we move may determine the benefits that we can obtain. Patients present to my clinical practice or are referred to the practice along any stage of the continuum of cancer care and their lymphedema journey. Individualised evidence-based care is provided using research, clinical expertise and patient preferences. If the patient does not enjoy it, they will not continue to do it. The approach to exercise is that movement is essential to life, but adjusting movement can assist in managing symptoms such as pain, ache, stiffness, tightness, mood, emotions, improve cognition, and manage lymphedema. Programs within the practice are land or water-based and may be group or individual, and patients can move across the various strategies to engage in activities. Moves for Life incorporates a discussion around changing movement to be more structured or loaded, more directional or purposeful, to increase intensity to more moderate to high levels, and introduces resistance to those of our patients who may never have done any resistance training in the past. Facilitating change and building self-efficacy within the Moves for Life really has 4 parts to it: education, competence, confidence, and then outcomes. I briefly discussed the first and final part of this wheel, but if you look at it further, there are a number of factors within each of these pieces of the pie that patients need to be able to move around and backwards and forwards to actually continue to participate in physical activity and specific exercises. The education component covers a number of factors that we have talked about before, with patients coming with prior knowledge, but they need to understand the cancer-specific benefits as well as the general health and well-being. Many patients mentioned to me that cancer does not define me. I was a person before I had cancer and I want to go back to it. So sometimes selling it around the concept of other health benefits and management of side effects, and listening with them around what their focused health outcome goals may be or their participation in life goals may be. For example, I had a woman who wanted to be able to get down on the floor with her new grandchild. She had never been down on the floor for over 3 years. She now gets up and down from the floor. The outcomes that we measure within this Moves for Life program are part of the patient's outcomes, but also every year we undertake a battery of tests so that we can monitor change for those who continue to participate in the program in the practice or those who come in for their 3, 6 or 12 monthly reviews to actually determine where they are progressing. So similar to what many places would use, we would use clinical assessments of strength, endurance, fitness and balance, lymphedema monitoring, both from clinical assessment, objective measures and self-report. But one of the other things is we also obtain investigation results around bone density improvement, cardiac function, and we document that we're progressing towards or achieving the guidelines and recommendations. So to facilitate change and developed competence, it depends on where the patient comes to us. Some patients will come with very advanced knowledge around exercise and physical activity. Others will come lacking substantial information. For many, it will be about learning new skills, or it might be to broaden the repertoire or to modify it so that it's more appropriate to them. But ultimately, we need to develop independence in being able to perform the activities that we're asking them to do. And for some, such as we did earlier this year, we introduced the Lift More program, but because we didn't have the same equipment from that research study, we then had to teach our patients how to use a barbell and then how to load it and to do it safely. They then were able to use this, fortunately, through the COVID-19 period, where many of them had purchased their own barbells and were continuing the program independently. If we then want to look at building confidence, it's setting the goals that are achievable and then celebrating the success that comes in achieving that change and being able to build in that outcome. And we need to be able to build in our patients the ability to expand and to self-progress and a willingness to try new things, but at the same time providing the support for ongoing review, which may be through telehealth means or in person, because this continued participation, there can be a sense of abandonment that I've told you what to do and you need to keep going. The feedback we have repeatedly is about checking back in with patients, checking in on what they're doing, why haven't they been able to do it, what barriers have arisen, what can we work with them to change it. This first case study that I would like to present is the ideal patient who presents to it. She came in September, having just had her surgery. She came with a very high level of knowledge around exercise and had previously participated and attended the gym regularly prior to her diagnosis. I have used her lymphedema monitoring to actually demonstrate that people will fluctuate during their treatment, and it is about when we're able to change things and introduce other things. So when she initially presented, we did not have a pre-operative baseline. However, after commencing her chemotherapy and continuing with her rehabilitation program, at 6 weeks post-operatively, she had full shoulder range of movement and a resistance band was introduced. She then chose to attend the YMCA cancer program that was available to her and continued this through her chemotherapy. She did not need to attend our groups or go further because she was able to manage and be competent and felt comfortable in what she was doing with the support from the group she was attending. Planned for her serial monitoring because of the association, she was a higher risk patient with lymphedema, that she then came in for review with her taxane therapy having been commenced. Following 2 cycles, following her initial reduction, she had now returned back to that initial post-operatively, which she then maintained until she commenced her radiotherapy. During her radiotherapy, by 4 weeks after her radiotherapy, with increasing inflammation, there had been an increase in her bioimpedance with a slight fullness in her upper arm. However, we elected to continue to increase with her gym program, and on review most recently, this is starting to decrease down. Compression garment has not been used, and we are continuing to monitor this downward trend. The second patient is a patient who has had long-standing lymphedema from her breast cancer surgery in 2012, which involved only 5 of 7 lymph nodes removed. She completed chemotherapy, high-risk radiotherapy with chest wall, axilla and supraclavicular radiotherapy, and continued on her tamoxifen. She had a tram flap reconstruction in June 2013, approximately 15 months post-operatively, 6 months after which she developed her lymphedema. She was, however, prior to COVID, managing very well with seasonal variations as well as increase from when she is on holidays, when she's unable to use her home pump and participate in her gym program that's outlined here. During our COVID shutdown, she had reduced her physical activity to, or substituted it to being walking 5 days a week, but she declined a resistance program to substitute what she was previously doing at the gym. This plot of her Aldex, which I have abbreviated to highlight the change. Prior to COVID, she was 34.6. The only difference in her management is that she was not attending the gym as regularly as she was. When reviewed subsequent to this, when our gyms reopened a few weeks after this measure, we are now on a downward trend to 40 with an Aldex. We are continuing to monitor this, but she has agreed to undertake bandaging should her measures still remain quite elevated from her usual fluctuation during her stability period. This third case study is a gentleman who is 58 years of age, who had a melanoma removed from his left calf in 2012, but presented to the practice being referred by his specialist 6 weeks after he had had a left groin dissection for recurrent melanoma in a groin lymph node. He has currently commenced immunotherapy, but on his initial presentation, he had a wound infection with a seroma lymphocele still present, and there were 2 areas of the wound which were not healed. At this point in time, we continued with wound management with compression. He declined to wear a leg compression garment, and the following week his wound had healed. There was a slight reduction in his clinical presentation, but he was reluctant to continue to use a leg compression garment at this stage. He undertook to introduce his physical activity, where we returned to a structured walking program of 15 to 30 minutes a day, and he resumed using his home exercise bike with the seat raised to avoid over compression in the groin area for 10 minutes a day. When he returned in 2 weeks, it was continuing to improve, and then we have ongoing improvement just using bike compression garments. He is not using a thigh garment yet, however has agreed, should his measures still continue to be in the yellow zone when he returns for review in the next week, that we will then introduce thigh compression garment, but has committed that he would most likely need it for flying and travel in the future. The final case that I would like to present to you is really about individualising the care. This patient is a young 33-year-old woman who was diagnosed with her breast cancer during her pregnancy in August 2019 and underwent an elective caesarean prior to starting neoadjuvant chemotherapy after the delivery of her healthy baby girl. She has spent the last 9 months completing neoadjuvant chemotherapy with the TCH regime. She underwent a wide local excision and axillary dissection in January this year and presented to the practice in March, having completed her chemotherapy, recovered from her surgery and was due to start radiotherapy but could not achieve the position due to shoulder impairment. She did, however, present with early onset mild lymphedema. This patient agreed to wear a compression garment, but also to introduce a staged exercise program to get full range of movement and then introduce resistance, which we continued to do through her radiation, demonstrating that we achieved improvement. She then decided that things were feeling and looking good and stopped wearing her compression garment, but has now resumed it again post-radiotherapy as she continues on her Herceptin. I routinely review patients 6 weeks after their radiation and then serially monitor for high-risk patients. However, in this particular patient, when we decided to discuss what we would do with physical activity, she said, I don't have time to go to the gym. I resent the time that I've lost with my baby. I haven't been able to do anything with her for 9 months. We then talked about the fact that she was in fact still postnatal, that we should look at mother and baby exercises, that she couldn't actually lift her 8-kilo baby girl above her head in play at the moment. So we have undertaken a program with this patient to build core stability, pelvic floor work, but also building endurance, and we have incorporated all of her exercise program to be in with the baby. So she does a lot of work in 4-point kneeling with baby underneath so that they can play. We're using the 8-kilo resistance of baby in all of our activities, and we are also making it fun. With pools opening in the next few weeks for us here in Australia, we intend to do an individual session with mother and baby to look at water-based programs with mother and daughter as part of that activity. So in summary, the approach for Moves for Life is that we have teachable moments, but we can have very competing priorities for our patients. The behaviour change model needs to be incorporated, and cognitive impairment, which we have not really touched on, may have an impact on patients' ability to perform exercises, but physical activity has been shown to have a positive impact on this. For patients who are left with residual sequelae from their cancer treatments, chronic condition management principles need to be an integral component in exercise prescription and physical activity promotion, but also in reducing sedentary behaviour. Ongoing support, guidance, assessment and outcomes is an integral part to this approach. And patients tell me they frequently hear me say, anything is better than nothing, something is better, but a targeted approach is the best. It's important to applaud our individual patients' achievements and outcomes, but also be adaptable. Our cancer patient is an individual, so adaptability is the key and most strongest part in building participation and ongoing engagement in physical activity and exercise. Thank you.